My job is a bit difficult because of the previous two lectures of Dr. Fairlings and Dr. Herbert. But I think the title of my talk is a mouthful, but really, when you look in the depth of my talk, is bouncing back to a very simple concept. We just have to interrupt ischemia, and we have been looking at the concept of ischemia for the past 40 years, and starting from the works of Arthur Cockburn and Hugo Rizzoli, and then Dr. Gregory Carlson, thank you very much, who that in preclinical studies, they really indicated that we don't have too much time. And that probably made the concept of Dr. Fairlings to call this process time is spined for the past 40 years. That we must and we have to really take it very seriously to take the pressure off the spinal cord after traumatic spinal cord injury. And in preclinical studies, we don't have more than a few minutes. But unfortunately, in human aspect of the traumatic spinal cord injury, we rarely have the reception of the patient within an hour or so. And why do we have to decompress the spinal cord so quickly? It's because of three things. One is because, as you see after this motor vehicle accident, the spinal cord is being squeezed inside the spinal canal from outside, and from inside there is the beginning of swelling of the spinal cord. So you have pressure on the neural tissue from within the spinal cord and from outside in the spinal canal by the bone and disco-ligamentous complex. So we must and we have to decompress that very quickly. And the reason for decompression is because we have three objectives. One is to immediately reduce the pressure on the spinal cord. Number two is to make sure that the blood pressure of the patient is up after traumatic spinal cord injury because of the spinal shock. And therefore, we have the option of increasing the spinal cord perfusion pressure, which has been shown that if we increase the perfusion pressure of the spinal cord, drop the pressure on the spine, and increase the blood pressure, we can increase the Asia motor score as time goes on. So we also have shown that if you decompress the spinal cord in a timely fashion, and if you decompress the spinal cord completely, therefore the chances of AIS grade conversion and recovery of function is 58.9%. If it is not decompressed, if the spinal cord is not decompressed, the chance of recovery of function is 18.5%. So this is my main concept of the timing of decompression and the extent of decompression, which has been going on for the past 20, 30 years. Starting with Dr. Papadopoulos, who suggested that we have to put the patient in traction immediately and reduce the extrinsic pressure on the spinal cord. And then after we reduce the extrinsic pressure on the spinal cord, we can have MRI and see if there is intrinsic pressure from within of the spinal cord, and then decompress it accordingly. Dr. Mark Hadley obviously gave us the map pushes. We have had a chance of reducing the extrinsic pressure on the spinal cord by draining CSF. And obviously, the person who has been for the past 20 years promoting the compression of the spinal cord has been Dr. Michael Fairlings. And recently we have seen by Dr. Papadopoulos in England that has proposed possibly decompressive laminectomy and expansive neuroplasty so that there is further decrease in extrinsic pressure on the spinal cord. But how can we really verify the fact that we have decompressed the spinal cord? One thing we have that we have learned is the presence of CSF around the spinal cord in the subarachnoid space. If we look at the brain aspect of the subarachnoid space, we have the dura, we have the brain, and we have the arachnoid. So if we see the CSF around the spinal cord, there we think that this is an indication that the chances of compression on the spinal cord is 0. So this is a normal situation. And there is another situation which we have to deal with, and that's spinal stenosis. Because we have patients that they are living with spinal stenosis and normal neurological examination, and they never never come to us because of spinal cord compression, unless is degenerative cervical myelopathy. And this is what John was talking about, is the third option of having a spinal stenosis and a simple fall and coming up to us with the central cord syndrome. So we have, going back again, let's repeat. Repetition is good. What is decompression for? Is to interrupt immediately ischemia. So how do we verify our decompression is complete? Is just by looking at the subarachnoid space and making sure that the subarachnoid space is open around the spinal cord as we look into the MRI or other ways of verifying that the subarachnoid space is open. So, Nathan, you have this patient with 6-7 translational injury. Based on what I said, how would you manage this patient according to what our champions of management, starting from Dr. Papadopoulos and up to the other Papadopoulos in England, what would you do with this patient? This is a bilateral locked facet. At the level of C6, C7, the patient is AIS-A or AIS-B, and you would like to...
I can sit here for it. So you said he's ASB at this point?
AIS/AB, and you have the patient within a half an hour at the University of Maryland. How would you manage this patient?
I would immediately try to reduce with traction in the TRU. Yeah.
And the objective?
The objective would be proper alignment of the spine to.
What was the objective?
It ideally would decompress as well, but you won't know that until you have an MRI.
The ultimate objective?
Decompress and stabilize, yeah.
Ultimate objective?
Improve the patient's neurologic function?
No. The second slide I used, interrupt.
Oh, interrupt ischemia. Sorry.
The ischemia.
Yes.
Because the bone is squeezing the spinal cord. Okay. You need to bring back the spinal canal back to normal and stop the capillaries and arterioles which are squeezed together and causing ischemia. And that ischemia causes what?
Infarction of the spinal cord. I mean, is that what you're asking?
Let's say that we have an MCA stroke, and you can save
neuronal cell death. So you have a penumbra that you're trying to save.
Exactly.
In that case, same thing here.
So you
beautiful.
Take the patient to the operating room after reduction, and this is what you do. Are you satisfied?
No, I would get an MRI at this point to see whether or not this is actually decompressed. Either way, you're going to need. I think you're going to need posterior fixation.
Let's stop. Okay. So you do have MRI available at any time at the University of Maryland, right?
Yes.
But somebody in India doesn't have MRI.
Right.
How would you know that this patient is decompressed or not?
You could evaluate them neurologically, but that's not going to tell you for sure. You could do a myelogram.
CT myelogram.
Another option.
Sure.
I mean, that's,
so, and how do you verify decompression?
CSF around the cord. So
around the cord.
Contrast in that case around the cord.
So we did the MRI post-operatively and read the slide number 3 for me.
See, we have the third one. So there's still compression at the superior, I guess that's a C3 lamina, at least posterior. Looks like there is CSF anteriorly there, but just underneath that C3 lamina, both ventrally and dorsally, it looks like there's still some compression.
Nathan, is there CSF from C5 to C7?
Yes.
There is CSF around the cord?
Dorsally, not ventrally. I think that's what I see.
Honestly? Nathan,
that's not CSF dorsally?
You're looking at the post-op.
Oh, I'm sorry. I was looking at the post-op image. I apologize. No, the patient is severely compressed from the bottom of the, that's from the C4 lamina all the way down to C7. Yes. I apologize. I read the wrong one. You said the third and I looked to the end.
So this is the problem that we have with the present arts of decompression in our literature. So you reduce, the patient doesn't have a spinal stenosis, you fused C6, C7, but when we look at the intrinsic swelling of the spinal cord, you really have not decompressed the cord.
Right.
That's why we did go one step additional, and that's what?
The laminectomy.
Laminectomy. Now, if you read the 5th slide, what do you see?
Yeah. So, I mean, you did a laminectomy from C4, 5, 6, 7, the bottom of like partial 1, and have very nice decompression at those levels. But as I was kind of mentioning, it looks like there may be some residual stenosis there with some at least decrease. I think there's some obliteration of the CSF space above, just at the inferior margin of that C3 lamina. Although, like I said, I think Ventrally, it looks like there's CSF passing, but dorsally, I don't see anything. So,
Okay. So, Nathan, if I'm looking at that MRI,
mhm.
I have verified that the spinal cord is decompressed in the fifth slide, right?
Yes.
Okay, so Nathan, what do you see inside why the spinal cord is swollen so badly?
The hyperintensity there.
Is there something inside the spinal cord you want to tell me?
Well, there's certainly going to be edema within the cord at that point. There's also going to be evidence of infarction at that point. I don't think
okay, stop,
focal hemorrhage.
Stop. What do you call what you see in the MRI? Intramedullary?
Oh, intramedullary lesion length is what we talked about.
Intramedullary lesion.
Mhm.
Or so
A predictor of. Okay.
what I'm trying to say is that
Mhm.
if you have the intramedullary lesion and its length, then you can pre-plan your decompression. Okay? So if you look at the next slide, which was pre-planned, what did we do? Just read the slides for me. Number one is...
This looks like a hyperextension injury. The first one, you have a dry CT of the C-spine, mid-sagittal cut. The patient has a hyperextension injury, I believe at C3-4. Otherwise, I don't see a fracture on that. I don't know if there's a injury. Maybe that spine
Nathan, we are talking too much. Nathan, in the second slide, tell me what I'd like to hear. In the second slide, what do you see?
Well, there I see translation. I see compression of the spinal cord.
It's compression of the spinal cord, right?
Yes.
So you have in the TRU, you have in your ED, you have an MRI that you are seeing compression of the spinal piece. Based on the previous slide, if you wanted to pre-plan your management, how would you manage this patient? This patient has about 45 millimeter of intramedullary lesion length. And then you know that it is possible that if you just go ahead with ACDF, the spinal cord is not going to be decompressed. Therefore, you add your laminectomy for decompression.
Yes, sir.
See, this is in the Staskis, for example, in Vakara's major paper in a randomized trial, this has never been proven that we have really decompressed the cord. Because we have the preoperative MRI, but we don't have the postoperative MRI. So, Nathan, if you have the laminectomy, if you pre-plan to have your laminectomy, and you have your laminectomy in the operating room, is there any ways you can confirm in the operating room without the need for postoperative MRI to confirm your decompression?
Confirm you've taken enough levels, but
you are in the operating room, the wound is open, the dura is...
You can palpate with the Woodson underneath the lamina to see if it's still tight. I mean, that's a little dicey in that case. Other than that,
have you heard the word
swelling?
Ultrasound?
Yeah, we could use that. Yeah, absolutely.
Do you guys use it here? No. Okay, yeah. So let's say that this is the ultrasound I show you. Just trust my words that you see the dura, you see the subarachnoid space, you see the cord, you see the vertebra underneath the dura, and you see it cross-sectional here. Now there you can do, you can look at the ultrasound as you perform it in the operating room, and you can confirm that the ultrasound has decompressed this marker. Okay, so this is some of the things that we are using at the University of Maryland right now as we pre-planned for what we are going to do. Okay, Nathan, for your pre-planning, what do you need?
We need to, so for the decompression, you need to span above the length of the
give me visually. You have your CT pre-op, you have your MRI pre-op, and you are in the TRU, you want to pre-plan your surgical intervention, you decide that, okay, I'm going to do laminectomy. what is going to, what do you need for planning to decompress the cord?
Intramedullary lesion.
Lesion length. So that's crucial. That's crucial that in your ED or in your TRU to measure the intramedullary lesion length.
Yeah.
Now, this is a case which is very interesting, and that's one of those cases that Papadopoulos at the St. George's Hospital in England is promoting for not only laminectomy, but also expansive neuroplasty, like what we do in decompressive craniectomy, right?
Right.
So, Nathan, the first picture that you see is the picture after surgery,
Mm-hmm.
and the second picture is MRI after the first surgery. And the third picture is the ultrasound related to the first picture, and you see a cut section. Is there anything that you would like to tell me about this? So this is your ultrasound in the OR.
Okay.
This is your MRI after I have done the laminectomy. Okay.
Okay.
And this is your ultrasound in the OR. Is there anything that you want to tell me? How is the decompression? You see the CSF over here. Is there CSF around the cord?
Not circumferentially.
This is your MRI postoperatively. You see CSF comes over here, stops here, stops here, stops here, stops here, and you don't see CSF around the cord.
Exactly.
Okay.
Yeah.
So even with laminectomy, this is a classic picture of Papadopoulos in St. George's, that even laminectomy cannot decompress the cord. So he would suggest to go ahead and do expansive neuroplasty.
Mm-hmm.
And we took the patient to the operating room, and we opened the dura and applied a expansive neuroplasty. And as you see, and this is the third post-operative MRI,
Mm-hmm.
and you see complete decompression of the spinal cord.
That's beautiful. This is a great dural patch.
This is fascinating. How much longer do you need approximately?
I'm going to be about 6-7 minutes.
Good, perfect. A recent, not yet published study that I reviewed from a UW colleague suggests not only to do an expansion neuroplasty, but also myelotomy it was, I think, just a rat model. Is there any benefit to kind of go deeper and separate the cord further from the
Dr. Chapman, from all the decompressions that we have had, about 15% are the type of decompression that Papadopoulos is talking about. So there are only 50%. And in those 15% that we have done expansive neuroplasty, almost all of them is enough. There is no need for myelotomy to bring out the intramedullary bleeding. And intramedullary bleeding is it measures about 5 to 7 millimeters in diameter, so it's not too high. Okay, so this is how to verify. Now, I want to show you a very simple algorithm how you decompress your spinal cord. And so in your decompression, you need the intramedullary lesion length, right? Because intramedullary lesion length also predict outcome. The longer your intramedullary lesion length, the worse is going to be your outcome. The better your decompression, the better your outcome. If you look at this slide, we see that in the patients that they had full decompression of the spinal cord, AIS grade conversion was 58.9%, and in the patients who had less decompression was 18.5%. So, and the third slide is that your laminectomy has to be proportional to your intramedullary lesion length. How do you do that? Because as you are closing your patient in the operating room and you have done your laminectomy, let's say you are 8 hours after trauma and you are 2 hours after surgery, you are on the 10th hours after trauma, you see that and you say that I have decompressed the cord and I'm going to close. This is not the case because that cord is continuing to swell up. And the swelling of the cord continues up to 48 hours. So you have to compensate for the next 48 hours also and add your level of decompression to that level of decompression that you're. Nathan, did you understand what I said? So you take your.
You have to decompress beyond that intramedullary lesion length because it's going to expand.
Continue
so
swelling.
If you just span it and don't get maybe a level above or below whatever prediction we can have as to how much more it's going to span,
right.
You haven't adequately decompressed.
Right. So if you look at the curve, it's logarithmic. Within the first, the MRI of at the time of admission, which was 5.5 hours, the intramedullary lesion length is 68 millimeters. And at 42.5 hours, which is post-operative MRI, the length of lesion is 102 millimeters, almost 10 cm. So you haven't decompressed the cord. You have to compensate for the number of hours beyond your decompression, which is about 2 days. Okay? So a second point is that in patients that you have AIS Asia A and B, your cord swells. In AIS C and Ds, your cord does not swell. The AIS C and D is true in what condition? In the condition that John was talking about. Many of the central cord syndromes that they come in, they are AIS C and Ds. In those AIS C and Ds, there's not much swelling of the cord. So I have put this together. It's not complete, but we are working on it. So you have a spinal cord injury. You have two conditions. Either your spinal canal is normal or your spinal cord is stenotic. In the majority of the spinal canals that they are stenotic, the injury is going to be also not very severe. So you're going to have acute traumatic central cord syndrome with a small lesion, and you are going to have patients with normal spinal canal and major injuries, and that's going to be the first group. So in the first group, you're going to have swelling of the spinal cord. In the second group, you're not going to have swelling of the spinal cord, okay? Now, measure your length of lesion in the TRU, in your ED, which is usually in AIS grades A's and B's, is nearly about 40 to 50 millimeters. Add 20 millimeters for the next 48 hours, which is going to be about between 60 to 70 millimeters. Divide that by 15, which is going to be your decompression for every level of laminectomy, and that's the number of levels of laminectomy that you are going to have. Thank you.